Welcome to the MDedge Psychcast, the podcast for psychiatrists that drops every Wednesday. I'm MDedge editor Gina Henderson, in for Nick Andrews. Today, we are thrilled to present an interview by MDedge Psychiatry Editor-in-Chief, Dr. Lorenzo Norris, of Dr. Michael Norko from the Fall 2019 GAP meeting in White Plains, New York. Dr. Norko of Yale University is lead author of a paper exploring whether religion is protective against suicide. He spoke with Dr. Norris about asking patients about their religious belief systems. The goal is to use that information to help patients reframe crisis situations and ultimately to help them find meaning. Should you reveal your own religious beliefs in these conversations? Dr. Norko and Dr. Norris explore that question and discuss when it might make sense for you to consult with or refer to religious professionals. You can learn more about the episode from the show notes written by Dr. Jacqueline Posada. We'll be right back.
Hello, I'm Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. Today we are pleased to welcome Dr. Norko, who is going to speak with us on a very, very important topic that concerns religion, spirituality, and suicide. So I really encourage all of our listeners to take heed with what Dr. Norko says, because we certainly are always in search of tools that we can utilize in a collaborative fashion with our patients to help prevent suicide. So Dr. Norko, welcome to the Psychcast.
Thank you very much. Pleasure to be here.
So, Dr. Norko, the statistics and the evidence in regards to suicide in this country are, at this point in time, well known. We are facing, whether due to the opiate epidemic, whether we're facing increasing suicide rates in the adolescent population, young adults, we are really have been seeing a rise in suicide for at least the past 10 years. So clinicians on the front line are always in search of what evidence-based tools or things that they can do to work in a collaborative fashion with their patients in regards to suicide prevention as well as protective factors. Dr. Norko, in that spirit, can you tell us a bit about what the evidence base currently says about the role of religion as it relates to suicide?
So the evidence demonstrates that various factors related to religion and spirituality are associated with a decreased risk of suicide. Those include regular attendance at worship services, commitment to a faith practice, and personal beliefs in line with a faith tradition's beliefs about the preciousness of life, that sort of thing. What we don't know necessarily is which factors about religion are completely driving this. There's evidence to suggest in part that it's the social networking of being involved in a religious community or the social contact within the group. Emil Durkheim's theory was it was about social integration. Mm-hmm. What we do know is that private practices are not necessarily protective. So people who engage in private prayer or their own type of meditation do not necessarily experience the same kind of protection. But people who live in countries or in states where there are a large number of people of a particular or many religious traditions generally have lower rates of suicide than those that don't.
Dr. Norko, this is really interesting. Let's take each one of these factors one by one, and let's kind of dive in and dig in a bit here. Let's talk about attendance. Has there been any evidence in terms of attendance? Because someone can go to church once a week, maybe once every other week. Some people may go twice a week. Some people may go twice a week and attend Sunday school. Is there any evidence in terms of increasing length of attendance as well as duration and that having an effect?
The evidence suggests that people who attend on a weekly basis regularly experience more protection than people who only attend occasionally. Now, whether that is a proxy for their level of social engagement with others in the community, or a proxy for their level of commitment or internalization of their beliefs. We don't really know, but it's just, this is the correlation that's seen in the research, is that people who are at a level where they attend services on a weekly basis exhibit more protection against suicide.
Okay. Now let's take a look at the next one in terms of, if you will, commitment to a faith-based practice. Can you first off elaborate on what you mean by commitment to a faith-based practice?
So people who don't just necessarily attend because they're expected to attend, but who internalize the belief structures, and it's an important part of who they are and what they think is a critical value in life.
Okay. All right. That's interesting. They internalize the belief structure. Now, when we say internalize the belief structure, do they have to internalize all aspects of the belief structure? Do they internalize, if you will, for lack of a better word, the meta frame of the belief structure? For instance, there might be somebody, let's just use something, that may believe in the general principles of the 10 Commandments, as an example. Right. I will use a Christian-based, if you will, religion, but may not necessarily believe in all of the doctrine per se of, for instance, the Catholic Church. Is that, if you will, commitment? Or is it like, do you have to go all the way in?
Right. So I don't think that you have to go all the way in, but I don't know of any studies where researchers have teased all of that apart. So if they've studied commitment, it's usually about judging whether or not people have a consistent and strong belief in the faith tradition, but they don't tease apart whether that necessarily entails believing every piece of doctrine or teaching of their faith tradition. And that's one of the complications for clinicians, and one of the important things to know is that just because someone says they belong to a particular faith tradition doesn't necessarily mean that the beliefs that they hold personally will or will not be protective. And so it's important to understand a little bit more. It's important for the clinician to understand a little bit more about the person's belief structures.
Absolutely. When I think about it, I think about, let's say you start going to church. I'm going back to my own experience. I went to a Catholic school, kindergarten through 8th grade, and I still remember having Mass every Friday, clockworking. You had to prepare the Mass. And on top of that, my father is a pastor of a Baptist church. So I would have Friday Catholic Mass, very lovely, ritualized, things of that nature. And then I'd go to my father's Baptist church on Sunday, also a lot of ritual, but a lot of a very different experience. And I think, but I do distinctly remember, at times, as most people would be like questioning, if you will, what are we doing and why? But then at times you can come to a point to where you realize the positive benefit of this practice for you in terms of, and kind of when I think about, if you will, commitment, as in addition to maybe the specific beliefs, but believing that this has a positive impact in your life, which to me is different than just kind of attending to attend. Right. All right. Please. And
I think that the people who would go would also experience a sense of being in a community with like-minded individuals and the support of that, so that in a time of crisis, they're probably more likely to fall back on their spiritual strengths and the support of their fellow faith community members.
Well, absolutely. When I think of the attendance, depending on the audience and how much people are involved in church. If you really think about it, if you go to like a typical parish or church or things of that nature, they actually have a bevy of activities spread throughout the week, whether it's Sunday school, young adult this, nights out, choir practice, deacons, the whole 9 yards. So one thing, depending on if a patient actually is depending on their religion, and they are of a spiritual bent, particularly I'm talking about when I'm on the front line on the inpatient wards, I always tell folks, church isn't bad, at all. I try not to be biased with it, but that you can go there and you can get a lot of what we are trying to do for you, if you will, sometimes in group therapy, particularly that if you will, that social interaction. So again, that idea of attendance and being around, what you said is so important, Dr. being around, if you will, hopefully like-minded people, but also I think the culture is working to encourage everyone to think in that spirit, whether or not you necessarily have thought that before. So, and now let's get to the third one, alignment. Elaborate a little bit more on alignment, Dr. Norko.
I'm sorry, alignment of?
I believe the third one that you said, there were three factors, attendance, if you will, commitment, and what was the third factor? Alignment with
their internal beliefs.
Okay.
Yeah. So people have to have a sense that for religion to really have a protective factor, it has to be more than you're just going to service to have your ticket punched.
Okay.
Right. You're not just going to obey a rule, but you actually endorse at some deep level the values that are being espoused by the tradition. And religious traditions universally value life. Mm-hmm. They universally value being kind to one another, compassion. So all of those things are life promoting, mm-hmm. and would be helpful to someone, particularly when they're facing a difficult time in their life. So that's a part of it that's important, is that the person isn't in a period of you could belong to a faith tradition, but if you're in a period of really having strong doubts and questioning, the religion might not actually be protective. It might actually be harmful to you. So, for example, if you had strong beliefs that were at odds with what your faith tradition taught, mm-hmm. you would be in a position of conflict, mm-hmm. and it might cause you to feel ashamed. It might mm-hmm. cause you to feel guilty. It might cause you to think of yourself as being sinful, and all of those things could actually increase suicide. So it's not universally protective. Right. There are situations in which it might be hurtful.
Right. I agree. And I mean, when you think about it, I mean, just when I look at, hear you talking about those three factors, I think about attendance. Where are you at? Where are you going? I think of commitment to a faith-based practice. What exactly are you doing in terms of your actual day-to-day behaviors while in church or throughout the week? And then alignment. Do your own internal values and belief systems align with what you are doing? If you got all three of those, then religion certainly could be a protective factor, if I'm hearing you correctly.
Yes, absolutely.
Okay. Now, Dr. Norko, what is it that clinicians should understand about, if you will, working with patients in regards to religion or asking about religion in their standard practice?
So I think it's important for people to include a religious and spiritual history as part of their normal history taking. Mm-hmm. Just like you would ask about people's family, about their relationships, their work. This is an important part of many people's lives. 85% of the world's population believes in a faith or belongs to a faith tradition. Mm-hmm. So it's an important part of people's lives. And when clinicians ask about it, you don't have to ask everything about it. You don't have to be intrusive about it, but you just need to ask, is there any faith tradition that you belong to, or are there beliefs that you espouse? How important are they to you? Is there anything about your religious beliefs that you think might ever be important for the work that we're doing together? Mm-hmm. And how, if at all, you would like us to address that in our work together? And just asking simple questions like that does a few things. One, it lets the patient know that it's okay to talk about religion and spirituality, because mm-hmm. Many patients come in thinking that their psychiatrist or their psychologist is not going to be interested in that, and, mm-hmm. and many of them aren't. And there are fewer people in the mental health professions. Mm-hmm. There are fewer people who are theists than there are in the general population. So there might actually be a tendency not to talk about it. Some therapists don't feel comfortable about it, but just asking and opening the door allows your patient to talk about it, and then it allows you to explore it. You don't have to be an expert mm-hmm. To invite the patient to talk about something that's important to their life. And then knowing that helps you understand who they are, what they're about, and if they get into a period where they're facing some new distress and you're worried about them, it gives you opportunities to help them refer back to their belief system, perhaps refer back to their support system. It might be an opportunity for you to get some consultation with a member of mm-hmm. the clergy, because sometimes someone, yes. for example, might have an erroneous belief about their own faith tradition that's leading them to experience intense guilt or feeling like they're worthless. And having that clarified with a clergy person from their faith tradition might be useful to them, but you wouldn't know that if you'd never engaged that discussion or allowed the person to talk about those sorts of things. So it just opens up other parameters of resources that you can engage to deal with a person when they're in a crisis situation.
Okay, let's dig a little bit deeper into that in regards to speaking with patients in regards to spirituality and religion. What do you have any tips for clinicians? Let's say you are of a Christian-based faith, and maybe you're talking with a patient who is Muslim. Do you have any, or of a faith that is different from yours? Do you have any tips for clinicians who may be who might have a bit of trepidation in regards to going in or talking to the patient about that topic?
So things that patients appreciate is the therapist showing an interest, and you don't have to know anything about something. So, for example, if your patient was really into NASCAR, you don't have to know anything about NASCAR to say, I don't know anything about NASCAR. Tell me about it. What is? And you can do the same thing with religion and spirituality. You don't have to know anything about the person's particular faith tradition to express an openness and a willingness to hear about it from them and why it's important to them and what they think it does for their lives. So that's the first thing, is that you don't have to be scared off about it because you're not an expert in it. I mean, none of us are going to be experts. We're not trained theologians or ministers. We're mental health professionals, but that shouldn't scare people off. The other is that, though, there are people who are professionals, and it's good to know when you might need to make a referral. Just like we'd like a clergy person who's counseling someone to make a referral to us.
Absolutely. When
things get out of hand and it's beyond what they can handle, we have to have the same approach with clergy persons and be able to acknowledge that this is perhaps beyond our level of expertise. This is really a kind of a spiritual or theological question that the person is having, and maybe they need to speak to a minister or someone in their own faith tradition. Okay,
let's keep going down this path. All right, here's some common things that I'm curious about your take on this, but these are some things that I may encounter in somewhat stickier situations, common, if you will, not common, but it does occur. If I'm asking about spirituality or religion, Dr. Norris, what is your faith-based practice? Any thoughts in regards to that, how someone might address that question?
Yeah, John Petit is a psychiatrist in the Boston area who does a lot of work in this, and he's written a lovely chapter in a book in which the way he couches his response to that kind of question is as an informed consent question. So when someone asks that question, he says to them, well, tell me how, if I reveal my own belief system or we talk about religion and spirituality, how will that improve or help the work that we're doing together to help you feel better? And so he wants to set kind of a boundary around it and make sure that that there's a legitimate reason for going ahead with describing that. The other way to think about it is that it's not terribly different from other self-revelations that therapists have to think about, right? Do you have pictures of your children on your desk? Do you wear a wedding ring? How do you dress when you come to work? I mean, everything about you reveals something. Patients see something about who you are, regardless of how close to the chest you're trying to keep all of that information anyway. So I think it fits into the same category of everything else that we need to think about when patients ask us things like, are you married, or that kind of thing.
Okay. All right, this another I would say common scenario: patient who is not only spiritual but religious, because those are two different concepts, but a very religious patient comes and they are in a state of severe demoralization because their church or their faith-based community has let them down due to, take whatever pick of public, if you will, incident, and they may say something such as, yes, I was deeply religious until X, Y, or Z occurred, and now my faith in everything is shaken.
Right. So I think at that point, you would simply want to, you'd want to be supportive first, obviously. And secondly is you'd want to explore more with that person what it was about their faith that helped them previously that's no longer there, and how can they think about regaining some of that through alternate means. I mean, maybe there's a different church group, or maybe they need to concentrate on doing voluntary activities at the soup kitchen or whatever it is. But there may be some substitute that you can help them think through. I mean, obviously, it's not our goal to prescribe to the patient what to do. Our job is to help them think through what it is that they're missing and how they might be able to replace that in their life in that situation.
That is hugely important. I want to combine that with something that you said earlier about knowing when to actually request a consultation from someone whose expertise is in spirituality. I'm very fortunate to work with Dr. Christine Pekowski at GW, GWISH. Yes, absolutely. So we've written chapters together. Yeah. And I love what you just said in terms of we need to be collaborating and asking the patient in terms of what is it that they sense is missing, and then again working with them to guide them to resources that may be of use to them, but not actually scripting out, well, you should do this or you should do that. Again, because I personally feel so we have to know when we're not really in our own wheelhouse. So, and that is a question or I will hear that in different various forms when I'm working in our ALS clinic at GW. So these are patients obviously facing end-of-life situations, and I will tell people, the audience conclusively, what my patients in ALS clinic taught me is that end of life is absolutely positively not a cause of depression. Many people are quite resilient in the face of this, and I thought that I would encounter many people that were more just melancholically depressed, and that's actually not the case. And I have noticed what you've been talking about in terms of religion and spirituality. That brings us up to another point. How can a clinician use this information in periods of crisis?
So if you know something about the person's faith tradition, about their background, their level of involvement, it can allow you to perhaps reframe some of the ways that they're thinking. It might allow you to make suggestions to them, or at least ask the right questions about helping them rediscover what it is that they've lost. And it may be that they've simply lost sight of the part of their faith beliefs that were most important to them because they got overcrowded by the contingencies of life, the accidentals, the things that we can't really control. And maybe you can help them find their way back to what's most life-giving about their beliefs for them, even in a period where they're disillusioned or disheartened by what's happening. The other thing is that it might give you clues to say, well, I remember you telling me that when you used to go to the Wednesday night bingo games, that you really enjoyed that. Maybe you should try to do that, or maybe you could call some of those people that you used to go to those activities with. So it just gives you suggestions for other things to remind people about that they might have become closed off to because of their depressive affect. And then the final is, I think that it allows you to know what realm of external resources might be available. So it might not necessarily, one of the important distinctions that you might have to make is this really major depression, or is this a person who's experiencing a religious spiritual crisis of disbelief? And if it's the latter, they might actually need to go talk to someone from their faith tradition, and hopefully someone that you know. I mean, you wouldn't. Hopefully, if you work in a community and besides opening up the discussion with your patients, if you've opened up discussions with faith leaders in your community, and you know some of them, you could say, well, I know so-and-so, he'd be a good person for you to talk to, or she'd be a good person for you to talk to, and you could make suggestions like that. But if you don't know, if you haven't asked the questions to start with, when you get to the crisis, it's kind of too late to start asking the questions now, because it will seem inauthentic, I think, at that point.
I'm glad that you said that in regards. I mean, I think that's the key thing. When you go and you're getting the religious history, and hopefully you're doing it in a fashion, the term I will use, I've said it before on the Psychcast, spirit of curiosity. Spirit of curiosity, sincere, authentic curiosity about understanding that patient's own unique life story as well as their own view of their own spirituality and religion. I think when you have done that, then you are in a place where hopefully you and the patient have actually discovered what that patient finds of meaning. And in periods of crisis, if I'm hearing you correctly, that's going to be the thing that you can talk about, that you can gravitate towards, that you can actually work with. Again, when I think about it, sometimes when I'm in at the ALS clinic, and you'll reach a point sometimes in therapy or even interviewing a patient where someone is very, very, very demoralized, on top of depressed, and they're not finding meaning in or they're having difficulty finding meaning. And what I like to think of is you go to a very dark place and you cannot see a way out of it. And that's when you have to rely on the work that you and the patient have done and basically tolerate the pain of that. I think I tell my residents that, a lot of times psychotherapy is just who can tolerate the pain, who can actually stay in the room long enough and tolerate the ambiguity, the not knowing, and let the meaning surface that we already knew was there. So when I think about that, or when I think about what you're talking about in terms of how we can use this information during periods of crisis, that's huge. Another thing that I would say is that this is a little bit older at this point in time, but I would say if clinicians have not actually looked at any type of, if you will, for lack of a better word, palliative psychotherapy or any of the work of Breitbart in regards to some of his work with meaning-centered psychotherapy in groups in terms of cancer survivors, I would recommend that it's a very useful thing to familiarize yourself with, just so that you can maybe have a framework in your mind in terms of how you approach, how you work with in collaborative fashion with patients. Dr. Norko, do you have any in terms of, again, we talked about like kind of general principles, but do you have any recommendations in terms of whether it's resources or things that clinicians can use to enhance their ability to work with spiritual themes or religious themes?
So, you've talked about Christina Bukowski. The FICA is something that is really easy for people to look up online, FICA, and the Gee Wish will sell you a little card that you can stick in your pocket if you want to be reminded of it. It's just a very easy way of thinking about how to engage the discussions. So that's certainly one thing. The APA also has a resource document on dealing with patients' religious and spiritual commitments. It's a 2-page document that's easily found on the APA website, and I think people should probably take a look at that. Just gives people some guidance to about how to engage in these discussions without becoming intrusive or trying to proselytize.
Absolutely. And for those who are not familiar with the FICA, the FICA stands for, if you will, faith or beliefs. The I is importance and influence. The C is community, and the A is address. The other thing, which is going to be in the show notes, I will find this for the show notes, that I want everyone to be mindful of when you are working with a patient, particularly in spirituality. A couple of things that I personally have found helpful, and I'm blanking on the if you will, not the resource, but the document, the evidence base for this, but I will put it in the show notes. The first thing I want people to think about is your own presence. I think if you're actually going to engage in this, you have to actually be present. The other thing is when you are present, you must be very certain that you are mindful and you're fostering a mindful, reflective presence in the patient. The other thing is, now this is a little bit, but we're MDedge, so I'll go there, but it goes right with what Dr. Norko was stating. You have to be in a place, that's that spirit of curiosity, where you and the patient, in my humble opinion, can discover meaning and awe in life. And once you do that, I definitely think that the spirituality, the religion, whether it's lost or not, you have an opportunity. You have an opportunity to find something that the patient finds meaning in. And I will again say opportunity, because I think if you go in with the idea like this is going to work, that's when it's not going to work. You have to humbly accept that you may not find anything. But I think if folks think about those things and engage in the work, regardless of the specific intervention, I think that they really have a very good opportunity. Again, I'll keep using the term collaborate with our patients.
I think finding meaning and awe is always healing, regardless of the situation.
And you can do that. I mean, we're here at GAP. I mean, you can do that looking at nature. You can do that anywhere. You can find meaning. But again, that mindfulness and being able to see it. And a lot of that, I was trained at Mount Sinai, and best clinicians in the world. My colleague, well, not my colleague, but my attending, Dr. Bruce Levine, is there, and one of the things I learned dialectical behavioral therapy. I learned a lot of different things at Mount Sinai, but I'm a believer of, and this kind of goes back to old school psychoanalytic psychotherapy. What we do to the patient, we should also try to practice ourselves or see what it is. So I encourage you, before you actually do this or any of these interventions or religious history, do it on yourself. See what your response is, see how you feel, and that's going to give you, if you will, a bit of a natural path. Dr. Norko, you've given us really a lot of information here in regards to, again, religion as a protective factor for suicide if we have certain things that line up. Again, and for that patient, again, we have attendance. We have a commitment to a faith-based practice, and we also have alignment, the internal values aligning with that religious or spiritual practice. Dr. Norko, what are your last thoughts or words that you want to share with the audience if you want them to walk away with something specifically?
Well, I think one thing I'll say is that, you mentioned G-Wish. I encourage people to go there. There are a lot of great resources there. And, you mentioned being mindful of this yourself in your own practice. They do retreats and seminars for physicians specifically who are dealing with burnout or the loss of their vocation and what brought them into it. And I've been to the retreat in Assisi, and it was wonderful. So I'm going to throw in a plug for that program and to encourage people to at least look at it and to think about it.
Okay. Now, again, and that to me illustrates what I think one of the most important principles, or I don't know if it's a principle, but it's something that I find when we work sincerely and authentically on behalf of the patient, it comes back full circle and we end up finding something that is of benefit to ourselves in our own life, because you touched on something that we talked about numerous times on the Psychcast, burnout, clinician burnout. And a lot of that comes down to the same basic things, being mindful and still being able to find a sense of meaning and awe, even in the setting of crisis or distress.
Absolutely. Dr.
Norko, thank you so very much for appearing on the Psychcast.
It's a pleasure.
Next time, listen for a masterclass by Dr. Alberto Espy on treating patients with Parkinson's disease-related psychosis. We'll also hear from Dr. Renee Kohansky next week. To check out past Psychcast episodes, go to mdedge.com/podcasts.